Welcome to Adapt NCLEX Fetal heart rate monitoring for maternity nursing. It's like EKG for cardiology. Very defeating when you see it. But at the end of this video, you will never be defeated when you see these kind of questions again. I'm going to show you tricks to answer this question and how to approach them. Stick around and let's learn something on fetal heart monitoring for maternity nursing. First question is about what? What kind of fact you're supposed to know to be able to answer the question. So I want you to take a pen and paper. This is a select or apply. This will be a teaching question. And now if you can stop the video and answer it, but I'm going to show you key things. That's why I highlighted those information. When you're answering the question, pay attention to those ones. So if you stop the video, which answer choice do you pick? I know you pick something, but this is the way we're going to answer the question, reading from the back. Which finding indicate normal contraction pattern? That means there's a normal contraction that is needed to be able to answer this question. A nurse is assessing a uterine contraction in a client in active labor using a external tochodynamometer, right? Which finding indicate normal contraction? There's a bunch of words in the question, but the one I want you to pay attention to answer the question is this. Normal contraction. That's all. And it's a select or apply. Just pick those that you're 100% confident. Now, what are the things you should pay attention to when you read the answer choice to answer this particular question? Number one, when you contracting, the duration should not be more than 90 seconds. If it's more than 90 seconds, it's bad. When you contract, how long should you wait? That means the interval is what? At least 2 minutes. Those are the very, very important information. Because of these numbers, you're supposed to have 5 contractions in 10 minutes. If you have more than 5 in 10 minutes, it's a problem. If the interval when you contract and you have to contract again is more than is less than 2 minutes, then you have a problem. If the duration, how long you contract, is more than 90 seconds, it's a problem. Those 3 numbers is all you need. Then you can talk about the resting tone. I will show you something that is easy. Contraction occurring 1 to 2 minutes. Well, it's a little bit faster, right? I told you the minimum you can wait is 2 minutes. Patient is contracting 1 to 2 minutes. Lasting what? Lasting 100 seconds. It's more than 90 seconds. So just by that, this is eliminated. The resting tone is too high. You need at least 20. When you know contracting, there should be no pressure. That's all. Contraction occurring 3 to 5 minutes. Yeah, it's more than 2 minutes. And it's lasting 45 to 60 seconds, less than 90 seconds. That's good. And there's adequate resting interval. That means you're waiting more than 2 minutes. Contraction occurring 6 to 7 minutes. It's very slow, but it's okay. But it's lasting, each contraction lasts for a long time, 120 seconds. That's wrong. The peak intensity has to be high. That means the maximum pressure you can have in the uterus when it's contracting, you want something like 80. Contraction occurring every 2 minutes. So this is in the borderline, but the duration is too long, 100 seconds, therefore. And there's no realization. That's the problem. Contraction occurring every 5 minutes. So it's a long time before they contract. That's good. And it's lasting what? 60 seconds. And the maximum pressure is 80. Therefore, this and that, B and E, are the right answer. But these are numbers I want you to write down and then be comfortable with when you see a question. And you have to know them. You can take a picture of them and then you can figure out next time. Now, let's talk about the EKG. Like I said, don't panic. I got you. Okay? And then she's caring for a client receiving oxytocin. This is the way the question will be. Wherever you go, this is the way. They have to give you a scenario. The uterine contraction pattern and fetal heart strip shown below. They will give you, this is the number, like an EKG. What is the priority nursing function? That means you got to do something. What would you do? First, go for the buzzword. It's a priority nursing action. They've told you about uterine contraction. So everything is in the image. That's all you need. Now go to the image and read the image. Every time you see an image, what would you do? So this is the image. You see the Top one is the baby, and the lower one is the mother. Take a picture of it, look at it carefully, and then look at the answer choice. Which one would you pick? Pause the video, select your answer, like a learning. Then, if you get it wrong, it's okay. If you get it right, keep on going. Then we go with the rational. What is the answer choice? Think about it. The answer choice is what? We continue to monitor. Why? Let's look at it. The mommy contraction is that the peaks are the contraction. The lower portion is always the mother contraction. That's the uterine contraction. So we have 1, 2, 3, 4, 5. Every strip they give you, you don't have to calculate in details. You can calculate the times and everything. But I don't want you to do that. When they give you a strip, it's standardized. That means what? Every strip, assume, is a 10-minute strip. Therefore, you're counting contraction. There is 5 contraction in 10 minutes. That is check. That's all. That's all you need. You don't need to calculate the duration or this. So far as you can see 5 in 10 or less than 5 in 10, you're good. Then the baby, I don't see deceleration. I don't see the baby heart rate dropping. If I draw a line from here to here, up here, baby heart rate is not dropping. All I see is some little bit of acceleration. You see, my mommy contract, baby heart rate is not dropping. And it's within 120, and there's variability. That means the top portion and the lower portion is going between 5 to 15, 20. This is good. So this is a normal fetal heart contraction. Therefore, don't fall for it. They will say increase Pitocin, place the client in the supine position, discontinuous Pitocin. Not every time you have to do something. It's based on the question. The question that we have, we don't have to do anything. This requires you to just read the EKG and see fetal heart monitoring. This fetal heart monitoring for nursing school and NCLEX prep is what? Normal. If it's normal, keep on doing what you're doing. That's all. This is the normal. 5 contractions in 10 minutes. Fetal heart rate is within normal. Did you get it? Stop the video, look at it again. We're going to use the same strategy. You know the strategy. Read the question from the back. What is the priority nursing action? That doesn't mean you have to do something. A priority action, you can still not do anything based on what they've given you. The nurse is caring for a client receiving with Pitocin and observe this fetal heart monitoring strip. Okay, what would I do? Stop Pitocin, place the client in the knee to chest position, place the client in the lateral position, notify the care provider. Don't worry about the answers. If you read the EKG, you will figure it out. If you read a strip, first thing I told you, don't look at the top portion, look at it down. I see, as I told you, 10 minutes. So I'm counting 5 maximum. I see 1, 2, 3, 4, 5, 6. And you can see the distance from here to here is shorter compared to the first one we saw. That's why they cease contractions. This is bad. You're not supposed to have more than 5. Therefore, this is greater than 5. Just by that, I know this is abnormal. This is what we call tachysystole. And then you look at the baby and see if the heart rate is dropping. It's not dropping. It's just not happy. His heart rate is higher than normal. And that's why you can see this wave is going up, up, up. Baby does not like it. This is tachysystole. And therefore, look at it again. So far as you have more than what? 5, we have tachysystole. What would you do? Will you let the doctor know? We place the client in the lateral position. Do you place the client in the knee to chest position? Stop the Pitocin. Always stop the poison. Always stop the poison before you do position. Stop the poison before you do position or IV fluid or oxygen or air care provider using your virtual mind. Look, always stop the poison. Therefore, stop the infusion. And this is what? Tachysystole. That's what we call it. Next one. A fetal heart tracing shows what? What is down there? Which interpretation is most appropriate? Fetal hypoxia, normal finding during labor, umbilical cord prolapse, and uterine tachysystole. You have to know that there is a uterine fetal heart monitoring. The fetal heart monitoring, there is one for every of these conditions. If you have fetal hypoxia, what should I see? If I have normal fetal and finding during labor, what should I see? Umbilical cord prolapse, what should I see? And urine tachysystole, what should I see? It's the same thing. You have bradycardia EKG, you have tachycardia EKG, you have SVT. Therefore, I want you to write it down. When I see fetal hypoxia, what should I see? So this is what we have. Look at it. I told you, always look at the bottom. If you have more than 5 classifies as tachysystole, I see what? 1, 2, 3, 4. So that's normal contraction for the mother. What is the baby now doing? So you've taken care of the first situation. What is the baby doing? After you know that mommy contraction is okay, what is the baby doing? So what you do, you draw your line. First, take the pic and then draw it to correspond to the baby pic, right? You can see the baby pic and mommy pic correspond, right? Here and here and here correspond. When the baby heart rate is all the way down, mommy is at the pic. Baby heart rate is all the way down, mommy is at the pic. And you can see the next thing is look at what happened when the mommy start to contract. When he start to contract, what happened? Does the baby heart rate drop right away? You can see here. As soon as you contract, baby heart rate go down. As soon as you contract like that, baby heart rate start to go down. Mommy stop contraction, baby heart rate goes up. Same thing. Contraction, baby heart rate start to go down. Mommy stop contraction, baby heart rate goes up. Same thing. Contraction, I'm going down. That means as soon as I start contraction, baby heart rate goes down. As soon as I start contraction, baby heart rate go down. That is equivalent to what? Early deceleration. When your heart rate go down, it's called early deceleration. Now, figure out what is that. If I see early deceleration, is it due to hypoxia? Baby is not getting oxygen? Or this is normal that we find during labor? Or is uterine cord prolapse? Or uterine tachysystole? Which one did you pick? Test taking strategy. It can't be tachysystole because we have only 4 contraction. Now, cord prolapse usually produce what? Variable deceleration. So 3C is gone. Now you're left with it. A is a specific fetal monitoring. I call it sinusoidal. I'll give you the answer, but there's a question there. You may stick around to watch that one. Therefore, this is normal. When you see early deceleration, it's head compression. Baby head get compressed all the time during labor. Therefore, this is the normal finding you will see. But this is a critical thinking, maternity nursing, fetal heart monitoring for nursing students to know how to interpret it. We interpretate that this is the early deceleration. What causes early deceleration? Critical thinking, adapt and close way. I don't want to give you the answer away. I give you information that causes what? Early deceleration. And then you find it is normal. That's all. Same thing, and let's note a fetal heart pattern on the monitoring strip. How should these findings be documented? That means how do you interpret this? Is this a early deceleration, late deceleration, variable deceleration? Is this an acceleration? Then you click it and you said, okay, I look at the mother, I see 1, 2, 3. There's only 3 contractions, right? In 10 minutes, that's good. But what is the baby doing? Then you go back and you said, I look at the peak, I see it corresponds with the peak. It corresponds with the peak when the baby heart rate is going down, but this one is alone. There's 2 things here you have to pay attention to. Look at this peak of the baby heart rate going down. This one looks like a valley compared to the first one we saw. It's like a curvature in nature. This one looked like a V. That means a sharp deceleration and it come up. Sharp deceleration and come up. Sharp one like that. When you see V's, those are specific. At the same time, there's one more key information. Look at this V. There's no contraction. That means the baby heart rate can drop anytime. It can drop when there is contraction, and there is drop when there is no contraction. This is what we call variable deceleration. And therefore, This is a variable deceleration. Okay? Are you getting comfortable? I hope you are. This is Adapt NCLEX questions in our Q bank. And if you like this video, subscribe to Adapt NCLEX, and then you can join our on-demand. I have a special on-demand videos where those videos from the crash course, and I use it for the on-demand, and they're precise, concise. If you're running out of time and you want a very short time to master those videos, and then you get access to this Q bank for free. So this is the normal sex. Which fetal heart rate finding is most assuring, right? There is fetal heart rates that are reassuring, right? There's some that are not, bad ones. Is it minimal variability, recurrent late deceleration, accelerate with what? Fetal movement, variable deceleration after rupture of the membrane. Which of these is a reassuring fetal heart? What do you think? Pick your answer and let me know. Pick your answer and let me know. I can tell you, minimal variability is bad. The baby heart rate is supposed to go up and down. If there's minimal variability, that means it stayed the same. Baby heart rate shouldn't stay the same. So that's what? Not reassuring. Recurrent late deceleration is bad, right? That indicates placenta insufficiency. Acceleration, baby is happy. Is moving around, happy. That's a good thing. Variable deceleration is not. Baby is not happy. That's deceleration. Another way to answer this question is deceleration means bradycardia. Therefore, if I see bradycardia, I'm not going to pick it as reassuring. The language may be confusing because it's a test. They're going to use those words associated with that specific concept. Reassuring means it's good. They cannot put the word good there. They have to use the word reassuring. And that's what I use. And therefore, a deceleration cannot be reassuring. And then you'll be left with A and B. And I see minimum. I know minimum is a bad thing. That means nothing is happening. And I'll pick acceleration then. That's how you break the answer choice. Which finding is most commonly associated with? Well, and next observe a smooth. Pay attention. Sometimes they will describe it and you have to figure it out. Wave-like fetal heart rate pattern with regular frequency and amplitude. That means it's regular, it looks normal, but it's very smooth, it does not have wavy edges, and it happened. Is the fetal baby asleep? Is it anemia? Is it normal labor progression or cord compression? Then you look at it. You see very smooth wave-like heart rate, fetal heart rate pattern, smooth, like normal amplitude. The height are the same. What do you think this is? What do you think? Is the baby sleeping, or baby have anemia, normal progression, or cord prolapse? What do you think? I can tell you, if the baby is sleeping, we'll have some bradycardia. Its heart rate goes down a little bit. If you have cord prolapse, it's going to variable deceleration. Normal progression, you're going to have jagged edges. It's not smooth. This is anemia. This is what we call sinusoidal. Very bad rhythm. When you see it, it may be hemolysis. Very bad. Fetal anemia is associated with this sinusoidal rhythm. So write it down. This is sinusoidal. I'm just giving you all the key EKGs that you should be familiar with when you see it in fetal heart monitoring. Now, I'll put all of them together. Once again, don't run away. I told you, I promise you, at the end of the video, you'll be comfortable. You will attack these questions as if you know them and you will never run away from them. Which strip was on the monitor? That means there was something the nurse saw. And nurse is monitoring a client in active labor. Patient is in labor. The fetal heart rate tracing shows recurrent late deceleration. Now, how do you know this is late deceleration, right? It's not variable, it's not early, it's late. So you do the same thing. We look at each one of them and he said, okay, what can I see? And I'll show you the trick to read it. This is the 10 minutes, right? I count 1, 2, 3, 4, 5. That's good. What is the baby heart rate doing? When I trace like that, nothing is coming down. You see what I'm doing? Nothing is coming. Nothing is coming. This is normal. I'm done. Then I go to the next one. And I said, okay, what do I see? I got to count. How many do I have? 1, 2, 3, 4. So this is good. But what is happening to the baby? I look at the peak and I see the peak correspond to the baby lowest heart rate. Lowest heart rate it correspond. Lowest heart rate is correspond. When does the heart rate start dropping? Right after the contraction. This is early deceleration. So this is not our answer. Same thing. I go to C and I said, okay, what do I have? 1, 2, 3, 4. I'm good. But then when I look at a pick, I draw it. Oh, there's no baby pick. The baby pick is shifted to the right. Look, the peak of the baby shifted to the right, shifted to the right. It happened and the baby heart rate start dropping at the peak. Heart rate at the peak. Heart rate at the peak. This is late deceleration. And we've seen the other one already. That was variable deceleration because of this. So this is our answer. Watch this video multiple times. If you have issues, check out that NCLEX. I have more videos like that. And let's note abrupt decrease in the fetal heart rate that vary in time and shapes with contraction. Now, I want you to be able to, like, if I describe it, you should be able to pick the rhythm. They will do that. They will describe the thing, and there is no strip for you to look at it. Now, you should be able to interpret the strip on your own word. So, what is the question? Look at it carefully. Which condition is most likely causing this problem? The next note what? There's abrupt. I'm giving you the buzzword. There's a decrease in fetal heart rate, but it vary in time and shape with the contraction. It vary in time and shape. What does that tell you? Is it placenta insufficiency, head compression, umbilical cord compression, or maternal hypotension? You have to figure it out. But I'll show you the strategy. First, ask yourself, what kind of fetal heart pattern will lead to that? This and that. But pick your answer choice, and I'll give you the strategy to answer it. I'm breaking down in pieces so that you can get comfortable. You pick an answer? Thank you very much for doing that. And now hold on to your answer. Lock in your answer. Don't change it. Keep it. It's okay. We're learning. Now, uterine placenta insufficiency will cause what? First, you say, oh, that causes late deceleration. What is late deceleration? We saw that when mommy contract at the peak, that's when the baby heart rate drop. Here it said the fetal heart rate, it varies. It doesn't change at the peak of contraction. Therefore, this is gone. Fetal heart compression is what? Will lead to early deceleration. There is no varying. This one, it has to mirror the mommy. Is not varying. It has to mirror. This is wrong. Cord prolapse. What causes cord prolapse? What? It leads to what? Variable deceleration. And variable deceleration, there's mismatch. There's variation between the mommy contraction and when the baby heart rate dropped. And the word abrupt give it away. Therefore, this has to be umbilical cord compression leading to variable deceleration, and that's what you see. Test-taking strategy, very high yield maternity nursing NCLEX practice question, adapted NCLEX way. And maternal hypotension will lead to bradycardia, but will be decreased variability in the baby. That's not what they describe it. Therefore, we're picking this. If you have issues with this one, watch it again, listen to the explanation. If you have a question, put it in the comments. Or if you know how to answer it, put in the comment the way you approach that particular question. And this is the last one. This is my favorite because it's a trap. I know you know it. I try to trap you. Like I said, I'm trying to make things easy, but at least I got to make you think critically because it's a board exams. Which intervention should the nurse anticipate? The client in labor has recurrent variable deceleration despite repositioning. What would you do? Magnesium, amnioinfusion, C-section, or increased pitocin? Stop the video. Last one. Pick the answer choice that you think is most likely to be your answer and let me know. You pick one. 5 more seconds. Which one you pick? And at the end, I want to know your score. Which intervention should the nurse anticipate? That means what you do. A client in labor has recurrent variable deceleration despite repositioning. Variable deceleration is caused by what? That's the first thing you ask yourself. Variable deceleration is caused by what? Cord prolapse. That's number one. I don't see cord prolapse here. If there's a cord prolapse, right, what do? You need to chest position, right? But we've already done the repositioning. Baby still has cord prolapse. That tells you baby still has variable deceleration. That tells you it's not the cord prolapse causing the problem. There may be something else causing the variable deceleration. The second thing that can cause cord prolapse or variable deceleration is what? You break your water and you lose your amniotic fluid, and that pushes the cord out. Therefore, it may be there's no more fluid, and that's why we have a cord compression, will cause by amniotic fluid lost, and the individual will have variable deceleration. Therefore, we need to give them Amnioinfusion, and this will take care of it. This is Adapting NCLEX. Thank you for watching. 10 questions on fetal health monitoring. I need to know your score. You can put it in the comment. But if you like this video, subscribe to Adapting NCLEX and give us a thumbs up so that we can grow this channel. If you want all the videos on the channel, you can join our membership. That will give you some of the restricted video. But if you are running out of time and you want a precise, concise, very short time and this Q-Bank, then you got to join our on-demand. You can find it on my YouTube. It's on a different site. Take care of yourself. Good luck.